Good afternoon, everyone. It is my great pleasure to introduce our speaker today, Dr. Louise Aronson. She is a leading geriatrician, a writer, educator, a professor of medicine at the University of California in San Francisco, and the author of the New York Times bestseller and Pulitzer Prize finalist, Elderhood, Redefining Aging, Transforming Medicine, and Reimagining Life. At UCSF, Dr. Aronson has served as founding director of the UCSF Care at Home and the Optimizing Aging Project. She's also director of the Pathways to Discovery program and the Northern California Geriatrics Education Center. And she's also chief of geriatric education. In addition to being a busy clinician and teaching, she also leads the Age Self-Care program, the UCSF Medical Humanities, and is the clinical lead for the senior hub of the San Francisco Department of Public Health COVID-19 response. Dr. Aronson has received numerous awards, including the Gold Professorship in Humanism in Medicine, the California Home Care Physician of the Year Award, and the American Geriatric Society Clinician Teacher of the Year Award. Her writing credits include the New York Times, Atlantic, Washington Post.
Please mute your microphone except for the speakers. Thank you.
Discover, Vox, JAMA, Lancet, and the New England Journal of Medicine. And she has been featured on NPR's Fresh Air, Today, CBS This Morning, Morning Edition, Politico, Kaiser Health News, Tech Nation, and The New Yorker. It gives me great pleasure to welcome Louise to be our speaker today. She's a wonderful speaker. I've had the opportunity to hear her multiple times in the past, and I'm looking forward to her presentation today. So thank you very much, Dr. Aronson, and I will turn over the mic to you.
Great. Well, thank you. It's nice to be here. It's morning in California. But I keep telling everyone it's 10. It's so weird.
Is it real? Yeah.
Oops.
Is that one of your glasses?
I'm going to mute that person. Oh, I can't. Okay, they're muted. Anyway, so my life has become all COVID all the time. So that's basically what I'm going to talk to you guys about today, and give you my very geriatrics biased view of the pandemic. Which this should be the right audience for, I think. Anyway, I'm trying to think how we can consider what's happened and how we can use it to move forward more effectively for older adults and geriatrics. So, I'll give my view. I want to talk a bit about structural ageism and racism. I'm going to focus more on ageism, mostly because I have greater expertise in that area, but I also want to emphasize the ways in which these are related and then talk about how we can really make things better based on this. So this is my brief biased history of the pandemic. It starts about a year ago, right? So we already knew from China, and I think in this moment a year ago from Italy, just how much this was a problem for our patients when you looked at the curve. I had up until that point been talking about, the decades of old age matter, but stages can depend on health and life expectancy and not necessarily chronologic age. And COVID has showed just how important chronologic age is. We also saw the very first pandemic in a nursing home. In March, we saw that what was happening in China and Italy was happening here as well. Surprise, surprise, but each country tends to need to prove this. And also that COVID was so much worse than the flu, which kills so many of our patients each year. Notably, we all locked down, right? But then we didn't think about what that might mean for older adults who weren't going to necessarily order online from an app and who were told not to go outside lest they die almost instantly. So this was some tweets from a young woman, I believe in Washington State, who said she went to the grocery store, and as she was walking in, she heard a woman yell. She went over and found a couple in their 80s, it turned out, who were scared to go into the store but had run out of food, and they didn't know what to do. So there was this way in which we shut down, assuming, taking an adult-centric and also a relatively privileged person, you have broadband or you can get things in a variety of ways, approach to pandemic, and didn't think about what that might mean for people who ran out of groceries but were told not to leave their homes. At this point also, we're hearing various reports from the field in geriatrics, although as one of my colleagues, Catherine Eubank, said, yes, it's very shocking, that COVID might present slightly differently in older people since everything else does too. But that aside, what counts as a fever, right? We know that our patients often have lower base temperatures, and we were already seeing that fevers were lower than what the CDC was saying a fever was. I remember hearing first from an AGS group that there was an Italian Facebook group talking about different symptoms. Again, not surprising. And people were chiming in from around the country on the AGS site about seeing new symptoms as well. So in April, I joined the response in San Francisco, and this was how our dashboard looked. So you can see deaths were 20. We weren't having the surge the East Coast was having, so we only had 25 deaths by April, 24 of which were in people 60 and over. So 60 is an interesting thing. A lot of people don't consider themselves old at 60; they consider themselves middle-aged. If you think about a distribution of death for, say, kids, that was as preponderant towards younger ages as COVID was for older ages, we probably wouldn't display the statistics like this. These are the deaths in people under age 18, if the vast majority of them were actually happening, say, in infants or in toddlers. So we did lobby to get our health department for the first time ever to break down older ages. And this is actually a trend nationally that I think is going to be really helpful to us as geriatricians. You can also see here how having a small sample size can bias your data, because this doesn't quite look like the official graphs, and now our graph looks like the ones I showed you earlier. By May, we're seeing a few other things. People are starting to cut home programs and day programs for older adults because the older adults aren't showing up. Now, this despite the fact, I don't know what was happening in Philadelphia, but in San Francisco, our programs were all adapting. They were trying to get devices to people. They were teaching people how to use the internet. They were delivering food to people's homes, people who used to rely on coming into centers for their one warm and good meal a day. But what this, and let me just say also that a lot in this presentation I'm going to use media, and that's because the media are able to respond more quickly than science. But for each of these things, I will show you come fall the science that proved the points the media was making earlier. So it's not an ascientific presentation. I just use what's available at the time and then follow up with data later, and the data will appear on the slide. So ironically, we're talking about cutting services to older adults that they weren't using, which would force them into nursing homes, which was where the so-called slaughter was happening and the greatest deaths by far nationwide. Meanwhile, in nursing homes, even in California, we had a relatively low death rate for nursing homes. So nursing home patients are less than 0.5 of our population. They were 35% of California deaths at that time, which was considered actually a good outcome for nursing homes nationwide. But we couldn't get testing there, even though in Hollywood, people could get tested every day. And we've seen that you can have super spreader events in the government and get tested every day. So definitely different priorities in different sectors. In the late spring, we also began seeing people fed up with being locked up. So this is a woman called Bethany Mandel who said, "You can call me a grandma killer." Can you imagine? Like, you can call me a young adult killer. You can call me a, fill in the blank killer. She wouldn't say that. I also find it particularly ironic because here's a picture of this woman with presumably one of her children. So she is what the geriatrician Joanne Lynn might call a grandmother in training. But as happens so often, and I think this is for all of us, when I became a geriatrician, I really thought of older adults as them. I think even you can know intellectually that it is your future, but until it begins happening to you, it's hard to really relate. And this is kind of what happens when we can't imagine old people as, sort of part of our same species, basically. And so you could see in Time magazine, The Road to Recovery, how targeted lockdowns for seniors can help the U.S. reopen. Let's just sacrifice a huge segment of the population. This is also because they don't see people who are functional as seniors. So were they going to lock down, Donald Trump, Nancy Pelosi, Mitch McConnell? Now you could argue locking down some of those might have been helpful, but anyway, they were, there's sort of the abstraction of older people and the reality. And people began asking, is age discrimination acceptable? And think of what was happening racially at this moment. Really interesting what people will do when they're othering others. This from Lena Macaroon, who's now at Pittsburgh, talking about rising rates of elder abuse. And indeed, these went along with child abuse and domestic abuse, the social isolation, the financial hardships, the people crammed into small apartments or homes together, the stress of the ongoing pandemic, and certainly rising rates of elder abuse in some sectors. Just to be clear, we're all on the same page. Elder abuse, an intentional act or failure to act that causes or creates a risk of harm to persons age 60 or older. So were we seeing structural elder abuse? I think we probably were. Nursing homes don't have to report pre-May COVID-19 deaths, so the deaths of those people don't count. They were sometimes abandoned and left to die. They were often without oxygen or care. Now, obviously, this isn't in all nursing homes, and I know, many of us have relationships with homes and try to keep them as top-notch facilities, but that doesn't negate the fact that we know horrible things happened. And in May, at this point, most health centers had decent PPE for a while. The federal government gave a whole week of PPE to the sector where almost everybody was in outbreak. So is that structural elder abuse? But at the same time, there's progress. So this is in June from the CDC, and look at how they've broken out the groups of people as they go older. Purple for people in their 40s and early 50s, early pink for early, for later 50s to early 60s, and moving on up. We have actually never seen this from the CDC for older adults. If you look, for example, at vaccination, you will still find 17 subcategories for children, 4 subcategories for adults, and then something called 65 up, which those of us in geriatrics knows incorporates 40 to 50 years of the human lifespan. So this is progress. The CDC now knows there are subcategories of older adults. Meanwhile, there was also this data on long-term care in June, which shows something we also know. Do we really think that physiologically there is a 4-fold risk for being an elder in Minnesota as to one in New York for dying from COVID? Of course not. We cannot divorce social context, medical context from the realities of risk. This has to do in part with the denominator. In New York, they had, what was then the worst surge. So a few things happened. There were lots of deaths among younger people because the virus was so widespread, and they were not counting older adults in nursing homes. They weren't even transporting them. So this skews the percentage that you get for deaths from nursing homes. There were probably other factors in terms of how well states count, how well they were set up to respond as well. So really, when we separate the social context, we end up with data like this, which suggests could suggest to some people biological differences that are really about how we respond to these crises in different places. At this point, we finally begin seeing some data based on race, although that reporting is still really different. So if you look at MMWR from a couple days ago talking about vaccination rates, you found that I think only 26 states were reporting based on race, and my own state was not one of those, unfortunately. So race gaps in COVID-19 deaths are even bigger than they appear. So this showing in the media, also some terrific articles showing that as you moved through this from the Brookings Institute, as you moved into the older ages, you could see that Black people remained at higher risk, and Latinx people second, and then white people, Asians apparently didn't even make the chart. Let's see if I can get this to, there we go. That didn't work. Sorry. Here we go. So there was also an important article at this point showing that nursing homes with reported cases were more likely to have a high Black resident share. And this is particularly notable, this article, because it corrected for many of the things we often blame on racial differences, so income, health insurance, comorbidities, public transit use of workers, really showing that there was structural and baked-in problems. We begin hearing by now about the morbidity and mortality of shelter in place. You know, we were already having an epidemic of isolation, and we were beginning to hear just how hard the isolation was on older people who at this point were having trouble with digital access. You know, lots of community-based organizations were scrambling to help, but we begin seeing data that's pretty concerning. Now this turns around, which is pretty exciting, and I'll come to that once we get to fall. In July, we begin seeing the first reports of excess deaths. You see here the dotted line is usual deaths. The dark line is deaths seen in 2020 up to this point, which I believe was August, was the end point, but something came out. Oh no, this part was July, and then reinforced in August. So the hashed line were COVID deaths, and then none not hashed orange are excess deaths. So what was that about? Well, part of it was about letting people not count COVID deaths, but part was that we couldn't get testing in places where people were most vulnerable. Or older people had atypical symptoms, and those have really been well characterized. I'll come to that in a minute, although I'm sure this audience is aware. I've been speaking a lot to other audiences where they still haven't heard about this. A lot of older people were afraid to seek needed medical attention for things like heart attacks and strokes because they were so afraid of getting COVID that they died of something else and a variety of other reasons, including where you live, which is pretty interesting. The first article on COVID presentations in people over 59 appeared in July, and it was a review of a bunch of other studies from March and April. Most of the studies came from China. They were multi-generational studies. There were many diagnoses missed because if you don't ask about certain symptoms that might be called atypical, even if they're typical in frail elders, you're not going to have them reported in your data. These were only about hospitalized patients, and it didn't mention long-term care facilities. The vast majority of studies they looked at were excluded, but they did find some interesting findings that I found useful, which is that typical symptoms remained the most common. Now recognize this is age 60 and up, so it's including a lot of middle-aged people. The atypical symptoms become more typical as we move through the decades of old age. Some typical symptoms more common, so GI symptoms, we're certainly seeing that, myalgia and fatigue, the so-called geriatric failure to thrive. And atypical symptoms were more common, dizziness, delirium, and in this study, anxiety, though I actually haven't seen that elsewhere. I wonder if that's one of the presentations in China. I don't actually know enough about that whether that has some culture-specific meaning. And most studies, of course, were excluded because they didn't separate out people by age, even though at this point there were months and months of data that the virus had very different impact on people of different ages, even across the decades of old age. In July, too, there was this article from the New York Magazine, No One Should Be Surprised That America Abandoned the Elderly to Die. Really interesting points about horrific totals were not inevitable. The virus was an efficient killer, but it had accomplices, and it talks specifically about decisions by governors and policies with a focus on New York and New Jersey, not surprising given the publication. But basically saying that nursing homes had to take people with COVID back in, even though they had inadequate testing and PPE, which basically led to more deaths of frail elders in order to unburden hospitals so that they could take care of people who counted more, namely younger people. In August, we begin seeing data that even among healthcare workers, people of color were nearly twice as likely as whites to get COVID-19. This had to do with the jobs people get, which have to do with opportunities and structural discrimination within our society. In some places, there was suggestion also of risk by availability of PPE. Later in the pandemic, we'll see how communities affected. The crosstalk between people's jobs and going back to communities also made things worse. And we didn't often see the connection, even at this point, although many of us were talking about it, between people of color being more likely to get sick and what was happening in nursing homes. Because in nursing homes and assisted living facilities, the pay for most of the staff is less than the starting wage at most other sectors. Meanwhile, those in charge of the biggest company were misusing federal money and still being given millions of dollars. This was sort of the geriatrics equivalent to what happened with restaurant bailouts, where huge multi-million or billion-dollar chains were bailed out, but mom and pop places that needed the money were not. And again, you see the multi-layered effects of privilege, where when people were doing not well within their facilities, some people could either take off work or work from home and bring their parents home and take care for them there. But if you were a certain sort of essential worker, you couldn't do that. And so you had to leave your parent in a facility, which may explain some of the racial differences in deaths by facilities as well, given the opportunities for digital work seem to skew very white. Shelter in place. Now, so here's where we start getting some better news. I realize there are parts of this talk that are quite depressing, but anyway, I'm hoping to galvanize us to make a difference. So at this point, we're seeing there's more than one story. Early in the pandemic, we were seeing all these reports, and indeed they have been documented in studies of increased loneliness, that where you lived really mattered in terms of what services and whether services were galvanized to help. That there are certain subgroups that seem to be at higher risk for having more trouble with shelter in place. So not very surprisingly, really, people with a history of depression or anxiety, with low emotional coping skills, with low social support, and people with higher functional needs that weren't being met as we saw services getting cut. And people being scared to go in to help people lest they kill them, but meanwhile they weren't helping them get along. At the same time, many elders adapted. Technology access and ability turned out to be critical, but there was a great study actually from Texas across multiple low-income communities, very diverse communities, I think on the Texas-Mexico border, that low-cost tech really helped depressed low-income elders and perhaps helped them more than going into the clinic. So this was something they liked. It didn't exhaust them to have to go in. It enabled the workers who were less well-trained professionals but geared up to do this to have better concordance in background with the elders and therefore address some of the social contributors, not just the medical contributors to their depression. A lot of older adults turned out to be more resilient than younger adults. When we look at the studies now, we're finding that rates of loneliness, isolation, and anxiety are lower in people in their 70s and 80s overall, not necessarily in facilities, than for people in their teens and 20s. In September, this from the great medical journal, The Washington Post, but they did a terrific analysis and looked at deaths in people with dementia since March through August. And there was this second uptick. And that was really thought partly due to the lack of people going in to help stimulate people with dementia who couldn't remember why this was going on and on and on. They also weren't being transferred even at this point. So there were more heart attacks, strokes, more lung infections. There were also more rapid cognitive decline, more falls. I mean, not getting family visits. In some places it's now for a year, but at this point it was many, many months. So nobody was coming to take you for a walk or anything else. And then this phenomenon of sudden frailty, which would have been an oxymoron until this pandemic and its lockdown. And realize too that at this point in many states, the ombuds people aren't allowed in any more than family members. Also deaths from starvation, where staffing was inadequate. I know when we've had outbreaks, we've had to fly in workers from some places, and suicides among those who could. And again, worse outcomes in Black and Latinx elders. There were also some articles around this time. This one from Sharon Inouye at Harvard and colleagues talking about the exclusion of older persons from vaccine and treatment trials for COVID. I actually will say that the NIH mandate that started, I guess, in 2019 to include older people where relevant has definitely made a difference. So yes, it wasn't proportional to the population in most cases, and certainly it wasn't proportional to the impact of COVID. But if you look at these trials, you will find that compared to studies of just a few years ago, there is much more inclusion of older adults. So I think the NIH mandate is making a difference, even if it's not quite adequate yet. So both good and bad news, I'd say. And then Tom Gill put this on Twitter that you all might have seen this. So in September, JAMA did a series of viewpoints about the pandemic, and they included 11 specialties, including pediatrics, but no geriatrics in this pandemic, where 80-some% of deaths are in older adults. So we've got our own sort of structural medicine ageism. In October, there was this case series of 76 hospitalized Parisian patients age 85 plus, so really talking our people. And they found the presenting symptoms were asthenia, so that's sort of a version of failure to thrive. Fever, common symptoms remain common. Delirium in 71%. So atypical symptoms are more typical the older and frailer the person gets. Inaugural falls and digestive symptoms. So really digestive symptoms in most series seem to be about 1 and 5 older adults. We actually are pretty sure we have a facility right now in San Francisco where the presentation is mostly digestive, although obviously we're checking for other agents as well. But pretty interesting here at UCSF, we tried to argue that falls should trigger a COVID test, and we had incredible pushback on that, even when we upped the age rate to 75. And here a tweet from a young geriatrician in Boston. Me writing all my clinic notes, so these are outpatients. Patient has declined significantly since the COVID-19 pandemic with new functional and cognitive impairments. I will say, and I'd be interested to hear about all of you, this has not been the case for all my patients, but I certainly have seen it, particularly in those who are most isolated, most alone, live in the smallest homes. I also think it might be true of me. So, but vulnerability to these things clearly goes up with age. So variation in racial and ethnic disparities, COVID-19. So this was interesting because it went across age groups. It's also from the wonderful Mary Bassett and her team. And I recommend it. It was in PLOS. So these charts sort of show you this is age and increase in COVID mortality. The top one is Blacks, the next one Latinx, the next one Native populations, and the last one Asians. So all increased over white. Again, making white the standard, which is itself problematic, but useful in this case. And for those who just want to see the numbers, look at this relative risk. It is unbelievable, and this is in people aged 75 to 84, so definitely the people we take care of. Rate differences of 889. So Black Americans are particularly the vulnerable of the vulnerable. They are 9% of people aged 65 and older, 37% of cases, hospitalization rate itself 3.8 times higher. And this from the New England Journal. Structural racism exists because discriminatory practices in one sector reinforce parallel practices in other sectors, creating interconnected systems that embed inequities. We've certainly seen this in our elder care facilities across the pandemic. And finally, in October, we get some data on the temperature metrics that we knew about from early March. So this is just showing sensitivity in blue and specificity in red. And you can see that if we use 38 as the cutoff, not so helpful. And these are VA and community populations. So they recommend better trigger temps in older people to be 37 centigrade or 99 Fahrenheit. And a bunch of us have been advocating for this, but as you probably know, it is not standard from CDC or anywhere else, even though they have very detailed information on kids. In November, again, more information about delirium, and now people in emergency medicine beginning to realize they are seeing this. So I feel like and this is one of the ones that actually has been added at UCSF and by the CDC. So good data on delirium, and more good news on mental health. So this looking at pulling a JAMA perspective article, pulling together the various studies showing that 8 months into pandemic, older adults are doing relatively well in terms of mental health outcomes. And that kind of speaks to aging and some of the U-shaped curve of happiness in old age, the ability to adjust and adapt. And sort of see the glass half full perspective. Clearly, if you're going to succeed in aging, you have to adapt to changes that you don't want in your body and possibly in your life. And at the same time, people are much more clear on what they value, and so are able to make better choices of how to spend their time. And all of that may be turning out to work to some people's advantage in any case. So this is from the CDC website, what I was just talking about. If you go in not as a health professional, but just as a member of the public, there is this Your Health site. And so lots and lots of categories telling you the things you need to know, symptoms of COVID, testing, vaccines, et cetera, et cetera. So it's great. There's this whole area for children and teens with a drop-down menu that's 9 long. Then there's I didn't do this quite right. So there's actually no mention of old people in this old people centric pandemic, but you can find them under people at increased risk. And so you have 2 drop downs for older adults, even though if you actually look at an 85-year-old compared to a 5-year-old, the risk is 13 times 630, data I will come to in a moment. Tremendous differences. Now, there has been some acknowledgement, right? So ACIP made residents of long-term care facilities right up there with healthcare providers as Tier 1A. On the other hand, the Trump administration made deals with CVS and Walgreens. So even though 1A was supposed to finish before we moved to 1B, in most places that hasn't happened. And why has that not happened? Because there is one system for long-term care and one system for everyone else. So states can say, well, it's not really our problem to deal with long-term care because the federal partnership is doing that. And if they're slow, or we can't not be vaccinating everyone else. There are some states that have really stepped up, like Colorado basically took it back from Walgreens and CVS and said, we're getting people vaccinated. And I know in California, certain county health directors have done something very similar. And LA actually did it from the very beginning, saying, why aren't we using existing systems to get the vaccine into places? Part of the problem in California was also that CVS had something like 16,000 facilities and Walgreens had 2,000 facilities, even though they have an equal footprint in the state. So you can see how problems are really baked in. In San Francisco, the Walgreens facilities were scheduled much sooner and more quickly than the CVS facilities. Some of the CVS facilities, people won't be finishing their vaccinations until April. And this is the data I was just referring to about rate ratios for different age groups compared to 18 to 29-year-olds who are here in the middle. So if you're a 5 to 17-year-old, your risk for COVID death is 16 times lower than if you're in your 20s. And if you're 85 or older, it's 630 times higher. And yes, part of that is biology, but it's so much more. And these are our people. They're at highest risk, and yet we're missing from the CDC website and everything else. So we have got to do a better job of talking about what this means and how much can be done, despite the fact that people are older and frail. We have abundant data. It's just that most people don't know it exists. So this is obviously not the end of the pandemic, and I realize we're a few days into February, but I haven't quite decided what to put in for February into my growing talk. What I am going to do in the next little bit here is go through some of the things that COVID have taught me, and then some of the things that I think we can all do moving forward, learning from this. So high risks of old age, Black and Latinx people. I'm going to talk in a minute about how actually those things can coexist, which the government seems not to have discovered. So they're seen as sort of competing groups as opposed to actual synergy, because it is the older people who are Black and Latinx who are at highest risk. Racism impacts health outcomes in both healthcare workers and in our patients and residents of long-term care facilities. And you can control for many of the things that we think determine disparities, and you do not eliminate inequities. COVID showed, and this is obviously anybody who knows my work knows this is my refrain. I believe there are three large categories of people. There are children, adults, and elders, and that each phase lasts decades and has significant biopsychosocial differences. I think COVID has emphasized that point. Telehealth works, but rural, low-income, brown, and older elders are less likely to have access. This is becoming a huge problem with vaccines. I'd love to hear what's happening there, but here all our big health systems and our governments are mostly pushing through text messages and emails, which is really not helpful for the highest risk populations. No surprise to this audience, long-term care and home health are not seen by many as part of the healthcare system. And really, every time we get new deployments at the San Francisco Department of Public Health, we have to really start with Elder Care 101 with the leaders, because they really know exactly nothing about this. On a positive, they're interested, but we can't deal with policy questions until we've had multiple meetings to give them the basics. The U.S. long-term care system, as currently constructed, cannot achieve its mission. I also kind of wonder, having spent a lot of time in assisted living facilities, of which there are 15,000 in California, can you have a lot of older people in a congregate place with no medical care? At the same time, I feel really strongly that we don't need to further medicalize older lives. So this is an opportunity. It's a huge challenge, but it's a huge opportunity for all of us. So how do we all make a difference? I think we should acknowledge some evidence-based facts about our profession and healthcare system, and these include that healthcare, medical research, and medical education are racist and ageist. I will say that I think we need to deal with the racism first, because at least with old age, you have lived that long. And I think we will learn some really important things from the race work that will help us going forward with age work. And obviously the two can be done together, but I think one could make a moral case that one needs to go before the other. Distribution of opportunity and power in medicine and healthcare is racist. So recognize that medicine can't be divorced from its social context. So you just see these differences, where if you look even at younger, older adults, some of whom are still in middle age, the death rates are just disproportionately Latino and Black. And part of that is those people cannot afford to retire because of structural racism and had to go to work and got sick. And because of structural racism, there's greater poverty, so also living with younger family members who were essential workers. And the corollary, I think, for medicine is that objectivity is the delusion of the privileged. I think this often when reading, clinic notes where people act as if this is the only note that could be written about this encounter. That's not true. There's a patient there and there's a voice there. Each of us has a voice, and what we note in our notes depends on who we are. What we don't note also depends on who we are. I think we must demand intersectional data. This works well for aging because it's, everything we do is complex. We deal with multi-morbidity, but I think until we figure out how to deal with complexity in data, we will never have very good data. In this specific instance, we need to be hearing about age and race. You occasionally get this. Some of the perversion of the data is sometimes that it's not collected. It's not collected by age, or race is not required to be reported. We should be raising ethical concerns. There was a nice article about this in December from Jiwa and Teaster. I'm not quite sure how to say that out loud, so apologies if I mangled it. But they sort of outlined the ways in which there are ethical concerns using the fundamental principles of dereliction of duty, autonomy, paternalism, and justice. And I recommend this article to really think about some of the things that are happening. So, for instance, there's been lots of abandonment of people in facilities. Meanwhile, states like my own is issuing staffing waivers. And the staffing waivers are actually most likely to be requested by facilities that have had trouble with infection control and violating rules for years, and that are more likely to care for Medicaid patients and patients of color, which means they're basically letting them off the hook for providing very, very substandard care to the most vulnerable people among us. There are also issues of justice, like the little access to PPE and testing that continues to plague facilities, and that really isn't even discussed where I am about elders in the community. We should be engaging in anti-racist medicine and geriatrics, and I'm not going to spend a lot of time on this because I'm sure you have people who are more expert in this, as do we. But I think it's pretty clear that we need to, and this relates to the not divorcing the social from the medical. In our EMR, it's really hard to get the social parts to show up prominently. So really addressing that's a way in which it's structural. Who is this person? How can you decide? Actually, one of the reasons I love geriatrics is because we often think about that. It's sort of part of what we have to do to determine values. But really thinking about social determinants of health not as add-ons, and thinking about how medical and American history influence what's happening now, including vaccination and vaccine hesitancy, and making trauma-informed care part of geriatrics. Similarly, this is being included in our facilities everywhere, but I think anyone who's been to an AGS meeting realizes that we've got a problem at home there as well. Okay, anti-ageist healthcare. My usual refrain: anytime a community, whether medical or not, is talking about kids and adults, we need to remind them that they need to think about elders also. Otherwise, we end up with, restaurants, movie theaters, and homes where people cannot live as they grow older. 90% of Americans want to age in place. Most homes are not built for that. COVID applications we've seen where there has been a ton of attention to children and adults, and to children with their much lower risk. It's not that children don't matter. It's an and, it's not an or. It's that if somebody has 16-fold lower risk and somebody has 630-fold higher risk, and you pay attention to the former and not the latter, I think you pretty significantly have a problem. So this is everywhere from information about COVID, presentations need to be included on the list of symptoms, distribution of PPE, priority for vaccination. We've actually succeeded at, although there are, of course, cheaters. Information equity, so this is from the San Francisco Department of Public Health website. So all of this in the middle is kids, and this tiny bit is older adults, and it's really only in facilities, even though 89% of our deaths are adults, and we have had 0 pediatric deaths. We're a pretty small city. We've got water on 3 sides, so that's part of it. We've also been much more locked down than other communities. Diagnostic equity, we all should be teaching the symptoms in older adults. And I've got throughout my slides the different articles that you can cite and quote. But people aren't sending COVID tests when it's COVID. One of my colleagues had someone come into the triage center, and people were going to send her home. It was a woman in her 80s whose family member explained that most of them had COVID in the household, and they still weren't going to test her. And her symptoms were seeming a little off and having fallen. And of course, she had COVID. At SFDPH, we've been saying forever that we have more than enough PPE. This is not true in our long-term care facilities, but they apparently don't count. And you also have to wonder that if younger people were dying at the rate elders were, would we have given masks to all of them? Is that something we might have done? This is a national map on the right of all the facilities that don't have adequate PPE, and recognize too that nursing homes have far more access to PPE than assisted living. They also have higher rates of infection and death because of their frailer populations. But this is a problem across the country. Vaccination equity. This was just a quick search the other day about jumping the vaccine line. Like, there are ways that'll tell you how to do it. There are things that tell you not to do it. There are people doing it all over the place. So, priority 1, yes, and lots of younger people are getting vaccinated all over the place. Ageism is everywhere, so my institution is very big on being non-discriminatory. Everywhere we go, we see this flyer or handout or, web ad, all races, religions, countries of origin, sexual orientations, genders, ethnicities, and abilities, but we don't talk about all ages. And indeed, if you look at our facilities, we do not welcome older ages. Maybe we don't want Medicare. It's a problem. I think we need to also focus on ageist anti-ageism. So these two are pictures from the Boston anti-ageism campaign, and I find them dangerous. Starting with the one on the bottom, she says, I'm many things, but I'm not over the hill. Well, if you think of a bell-shaped curve of a life or a narrative arc of a life, they both suggest that most of us are over the hill somewhere between the ages of, 35 and 50. So this woman, admittedly, is better looking now than I was at 18, but she is 86. She's over the hill. The problem isn't, is she over the hill or not? The problem is associating being over the hill with negativity, right? When you say, of course she's over the hill, no big deal. That's not her defining characteristic. But when we say, I'm not over the hill, we say that is a way of reinforcing the fact that over the hill is bad. And if over the hill is bad, then old is bad. And if old is bad, we don't get testing or PPE, and we have people sent back to facilities to die. Perhaps even more tragic to me is this man, age 83, saying, I'm a longtime boxer and I'm not frail. Well, we all know that unless he dies suddenly, he's going to become frail. And now he's created a world in which it's not okay to be frail, in which he has value now because he doesn't see himself as frail. And once he becomes frail, he will have no value. And so we could not count his death in a nursing home if he had died there before May, because frail people don't count. Our own group is part of this, I believe. This may be a controversial opinion, but in the fall, there was another article in AGS. Words like the aged, elders, the elderly, and seniors should not be used because they connote discrimination. Actually, no, these are just words. If you look any of them up, they all describe people who have lived longer than other people. It's kind of like saying, no, we shouldn't use toddler, tween, or teen for young people because they connote discrimination. The words aren't the problem. The ageism is the problem, and actually, if people could feel more comfortable using these words, there would be less discrimination, not more. And most civil rights movements, if you look at it, they pull back like, we're here, we're queer, Black is beautiful, own that terminology, use it in the way it was intended. We also need to tell the whole story about old age of people of different subsections. So if you Google the lifespan, you will get this. So there are 4 stages of childhood from infant, toddler, kid, and teen. There are 4 stages of adulthood. I'm in my later 50s now, so I'd say I'm in this, certainly after COVID, look at her hips. Yes, I'm definitely here. And then we jump right away to a wheelchair. So my mother is 30 years my senior, not yet in a wheelchair. Obviously a fortunate person in many regards. But what about everything else? And I think in geriatrics, we need to expand this conversation with terminology, but also pointing out that most older adults haven't died. Yes, there's higher risk right? It's a diverse group. And until we can get people to discuss the subcategories, we won't get recognition for the full diversity and subcategories of old age that mirror the subcategories of childhood and adulthood. So we need to be asking some tough questions. Are we sometimes part of the problem rather than part of the solution to long-term care? Do we need to have presence in local and states departments of public health to truly make change? It has clearly made a difference to have several of us there. They want to learn. They are doing things that are discriminatory, mostly because they learned nothing about old people in medical school or public health school. Are AGS and AMDA doing everything they can and should? Do political considerations sometimes outweigh what might be done for the sake of our patients? Are we complicit in our institutions' ageist inequities? And I'm just going to bring up the age-friendly health system, which has done some wonderful things. And in contrast to having at UCSF an entire gorgeous new children's hospital, we have what's called an age-friendly health system, where it's virtually impossible for frail older adults to get out of the parking lot and across the street. Although if they make it that far, they might get some attention to their mobility and medications. I think a good thing to remind people of is to create the old age you want to live. The photographs here are actually from San Francisco's anti-ageism campaign. And what I love is they show the older person in the eyes and the younger person on either end to show that in each younger person is an older person, and in each older person is a younger person. It's part of, hopefully, if we're lucky, all our lives. And with that, I will stop, and I'd be happy to discuss, take questions, whatever would be useful. And I did leave just a little bit of time.
Kojanowski, would you say a few words about the effect of aging on people with neurodegenerative diseases such as Parkinson's disease, Alzheimer's disease, frontotemporal dementia? Do they have different vulnerabilities, more vulnerabilities, the same vulnerabilities to age as other people with everyone, will have some disease, heart disease or what have you, but are there special things that you think about when you think about aging and neurodegenerative disease?
Ooh, that could be a whole topic. Definitely. I mean, you could consider it a way of having accelerated aging and increased vulnerability. If you think about Yeah, just because I just mentioned the four M's, their their medication reactions that are different and increased, different reactions depending on the neurodegenerative disease. There's increased risk for cognitive decline. There are physical higher risks. And I think that ties into the system also. I don't know what you guys find, but when I order PT for an older patient, they're often happy if they can move, the PT is often happy if the person can just move around with the walker. And so I think pushing harder that we've known since New England Journal articles in the 1990s, this was part of why I became a geriatrician, that you can build muscle mass. So that'll depend on the neurodegenerative disease and the parts of the body affected. But it seems to accelerate certain aging processes and the vulnerability to things to which all older people are vulnerable. Again, I can't really do that justice in such a small amount of time, but
That's
yeah.
good. Are there predictors of rapid aging-related decline? I'm 74. I feel in good health. I work out. I'm very active, but I don't know what I should look at to predict that I will decline in the next 2 years or 5 years or 10 years.
Yeah, well, again, there have been certain studies that look usually at functional ability, there are functional reach studies, there are gait speed studies, things like that.
So
The
those are good
highest risk,
predictors. Those are good
um,
predictors of
well,
staying
those are
healthy or
proven
declining.
predictors
Proven predictors. Okay.
of decline. So the absence of them might mean that you're doing better.
Okay.
But I think, we know correlates. We don't really have randomized control trials for many healthy aging things, but certainly activity, nutrition, sleep, and stress reduction seem to make a difference.
And we do have some questions in the chat. So I have asked those people to unmute themselves and ask. If it gets too confusing, I can take over.
Thank you so much. I really enjoyed your presentation. This is Pam Cascione. My mental health and aging class has joined us today for this presentation, which is really wonderful. And I really appreciate you touching on the mental health aspects of your for older adults. Can you discuss a little bit about the whole concept of reframing aging that GSA and AGS has been working so hard on? And based on your comments about owning aging terminology, what's your opinion on how we should reframe aging?
Such a good question. So I sort of love that we worked on reframing aging, and I used a lot of what that effort showed, in the we. I mean, it was really helpful for me in moving to a we and an us instead of a them. Although I have recidivism, which I might have displayed in the last hour. I can't actually remember. It's sort of funny. So I think that did a lot of good. I loved that they presented data on what does the media do, what do professionals do, what do the public think. It's really helpful to know where we're at to move forward. But I do think pandering to ageism, why are they saying not to use those terms? They're saying not to use those terms because people don't like those terms. Why do they not like those terms? It's not because there's anything wrong with the word. It's because they have internalized ageism. So I feel like we're not addressing the root cause. We're addressing, the symptom or maybe even the frosting on the symptom. And I really push back on that. For the book, I let my hair go gray, as you can see. So now when I'm dealing with our trainees, a gray-haired person when you're in your early 20s, and, I was like this way back when, you can't necessarily tell the difference between, 57, 72, whatever. So I just started using the terminology, and it's really interesting because you can get people used to not saying, oh, you look great, or oh, you're not old. And I'm like, I'm clearly older than them. I could have given birth to them. So it, and I say, I'm actually fine with it. I'm very happy. I like being me. So I just think you can get yourself used to it. It took me a while, and part of how I got there was that I had started to make those aging comments around when I hit 50. And I'd be like, "Oh, I wish I could go running. You're going running, blah blah blah, my stupid foot." Um, so I just think we need to work on the root causes, and we need to be comfortable ourselves, and having all of us model it and work with our patients to teach us how to do that better. There is also, Becca Levy's work from Yale, which, Lisa probably knows her, given her Yale years, really shows that perceptions of aging, positive perceptions of aging lead to better, healthier aging, and negative perceptions do harm. Yes, it's not necessarily a full RCT, but it makes enough intuitive sense. And there is a growing literature generally about positivity, which, admittedly might have correlates to having been born, wealthier and luckier. But I do wish we would attack the root cause.
Hi, I'm Kelly.
Thank you.
Oh, I'm sorry.
No, it's okay. You can go.
Oh, thanks. I'll give it. My name's Sean Kelly. I want to ask, especially now, given COVID, given the boomers, given the changing demography, given what we know about outcomes and the stress on the hospitals and the health system, what's being done to encourage, intersection with long-term care and healthcare, and maybe what could we be doing? I mean, I'm in the LTC space, and the frustration over, the COVID era, I think, magnified existing conditions that feel like a call to action. And I was just curious thoughts on that.
Yeah, I completely agree. This seems like a huge opportunity, and to think of long-term care broadly, right now, if you're talking nursing homes or skilled nursing facilities, that goes under state departments of public health. If you're talking assisted living, that goes under state departments of social services. And yet so many of the problems are so similar and related, and we're certainly seeing some people in assisted living places who could easily be in nursing homes. So how do we, and then we have the whole aging in place phenomenon and a whole generation of people who aren't going to be as quiet as the silent generation or the stoic great generation. And who don't want to go into these places. And I think, unless you yourself would want to work and would want to live in the place where you work, then we need to be, are there some assisted living facilities I could imagine living in? Yeah. There isn't a nursing home I'd like to live in, even the nicer ones. So how do we do this? And I have more questions here than answers. There is a group that led by Mike Wasserman that's really thinking about pandemic response, but might move into thinking about how do we reform this. There's a tension here because you've got states in charge of a lot. There's a little more federal oversight at nursing home, but no federal oversight, no even collection of statistics. Like there's been a single article about assisted living. And that was kind of what people chose to share. Assisted living also goes from, 400 bed CCRCs to 4-bed, boarding cares. So it would be great. I mean, this is another thing where, AMDA and AGS, we should be forming think tanks, but also not just with us, but with, architects and designers and community members and everything else. And to integrate these places into communities rather than making them this separate world where you can put older people and ignore them and not even walk by it and think about them. I mean, it is really that creating that future we want to move into. What could we do differently? How do you provide medical care and oversight without medicalizing people's lives? So I think lots of good questions, but the sooner we get started, we might have people's attention now. I think that will be great. I think Kelly was next.
Yeah, Hi, I actually worked as a research coordinator at UCSF, so I appreciate you owning how horrific the walk is from the parking garage to the hospital.
Isn't it insane? Like you clearly don't have cognitive impairment if you can do that.
As a young 10-year-old, I could barely figure out how to get from one spot to the other. But Anyways, I'm curious more from a clinical, more individual interaction perspective. When you really like to start supporting people in planning for whatever they want their aging to look like. And I have just a specific interest, I think, for patients you're maybe seeing whose families have moved away and maybe don't have a very strong nearby proximity familial support network.
I've made it one of those things I raise with all new patients at this point, because there is also that thing that one of the things everybody hates about aging and old age is the loss of control. So I try and frame it as, the more we plan, the more control you have, and the more we make it in keeping with your values. And it also raises one of those great sort of aging adaptation things, which is, really important to know what matters most. You may not always be able to do it the way you want to do it, but try not to start with the negativity and really to start, because that's part of advanced care planning of, broadly writ. People often think about that as just like, do you want me to thump on your chest? But I really think about it in a big way of, and I try and get people to think about occupationally. And by occupation, even that, I don't necessarily mean paid work, but equally, if you're doing valuable work, you should get paid. But it's that purpose and meaning thing. So thinking about how do you keep purpose and meaning in a person's life throughout their lives, and what are their options, and what matters most about the home. Actually, for the Age Self-Care Project, I'm working with a few community groups. So one is San Francisco Village, part of the Village movement, which can help people age in place, although really skews towards middle to upper middle class, which they need to work on and hopefully are. And another group called At Home with Growing Old, which was founded by a social worker and an architect. And so the architect talks a lot about how to make your home a place that increases socialization and social opportunity.
Well, she's still on, Virginia. I can hear it very
and that has delight
weakly, but I can
and
hear it.
other, if I can manage. Anyway, so really thinking about, is it the home that you need to adjust, or you, or both? Socially, what are the options? As people move through their 70s and into their 80s, a lot of the people, even for people who had connections, they're going to lose siblings, partners, friends. And so how do you introduce some new people into your social environment? And it's also important when doing that to recognize it's not going to be the same as the person who's been your best friend for 78 years. That it's not going to be the same. And yet, it will be lovely to have a friend if you're a person who likes having friends. So it's all those things, and I bring them up. And I'm in this clinic now where I bill by time, so I don't, I obviously couldn't do this in 15 minutes. And it's a still overtime conversation, right? But that also talks to what I tried to talk about in elderhood, which is that, we can't really make geriatrics what it could be without reforming the healthcare system and primary care generally. And that's so broken. We're ranked 37th and we think we're such hot stuff in healthcare. I mean, that's just, it's delusional.
Louise, I had a question, but I think Christine, I saw your name listed before. Did you want to ask your question?
Yes, thank you. Hi, my name's Christine Brewer. I'm a doctoral student in nursing at Villanova outside Philadelphia. Can you hear me?
I can.
Okay, good. I am studying nursing students' preferences for working with older adults, which you have hinted at medical doctors' lack of interest or lack of preparation. And so I'm curious what you think, because we haven't, perhaps some of our education has improved in geriatrics or gerontology, but we do not see an increased number of nurses, doctors, or other healthcare professions wanting to really focus on working with older adults. So I just want your thoughts on that.
Yeah, no, that's kind of a tragedy across health professions. And In nursing, you used to be able to do a GNP, and now which was the geriatric nurse practitioner, and then what is it, like 5-6 years ago, it moved to AGNP, which just like lowered the amount of geriatrics knowledge, while maybe meaning that more people have some, but fewer people have lots, something like that. Anyway, so my nursing colleagues and I were having many conversations about that. Should there be an AGNP and then also a GNP? But I think often, and in geriatric medicine, so they lowered the training to 1 year to try and get more people, and that didn't work, and they didn't reverse it, and it just it reinforces the notion that this isn't really, it's not a big deal. You can do it in a year, and other fellowships are 2, 3, and 4 years. Not that I'm necessarily saying people should get a really bad salary for even more years. But maybe we should have more people short tracking. Like if you're really just going to do geriatrics, you do 4 years total. 2 is internal medicine or family medicine, and 2 is geriatrics, and yet we did this long time ago, and don't change it. So I think both nursing and medicine should look at the changes they made to make things better. And if they haven't made things better, once again, I don't think we're dealing with the root cause, and the root cause is systematic ageism and people being told don't go into that. It's no fun. I think it's really good to get out and do as much teaching and role modeling as you can do, but there are also financial and structural incentives. And I think that also comes to this idea. I was on a call yesterday about burnout, and an expert on student burnout was talking about one of the things that leads to the most burnout among trainees is I want to say complexity, but it's not that. It's uncertainty, right? So if you can't deal with uncertainty, you're going to love geriatrics. No. So what happens is, you go into anesthesia and you're like, okay, you're asleep, and now I'm going to give you this drug and I'm going to inject that, or you go into ophthalmology, I'm going to deal with this part of your body. So we really need to start from the bottom. But I think we also need to show the good outcomes and how satisfying it is, and make more about that. And all the things that can be done. And maybe I'm sort of hoping too that maybe this moment where we're acknowledging more social things, we can get more acknowledgement that that's actually part of medical care. I have a young research assistant who's interviewing for medical school now, and she interviewed somewhere actually in your area. And had worked, she took a year off, she wants to be a geriatrician, took a year off and worked at an adult day health program. And so the anesthesiologist who was interviewing her was like, well, so why aren't you becoming a social worker? As if that was like disdainful, and so I worked with her in framing, that's a great question. Social work is wonderful, and I want to, do both these things to get, et cetera. So, I think there's probably some gender in there, right? Who did social work and who did medicine. I think that's a lot built in. I so haven't answered your question. As you can see, I could talk on this topic like forever and ever and ever, but yeah, be enthusiastic, recruit people, make it fun, show up so they can see how much fun it is, how important it is. Show them the wins. When you're young and you're feeling insecure, it's kind of like when the trainees get to the point they know the terminology and then they're using them with the patient, and the patient's hearing like, wah, 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 and you're like, you need to speak English to the patient. Yeah, I just think we have to amplify our voices. And I'm hoping that boomers will start making noise and make it more attractive too, like partnering.
Louise, I had a question for you. I was just wondering, in terms of your thoughts with the pandemic, what do you think that impact will be? The impact will be on ageism, structural ageism. Will it make it worse now that we recognize that there are differences, that 65 and above is not just one group? Will it make it better? I mean, obviously it's kind of speculation. I'm just wondering, from your vantage point and the way you see things going, what do you think will be the long-term effects of how COVID impacts how we think about ageism and structural ageism as it exists?
So unfortunately, I I have reviewed some articles about this, and one of them's been published, so I think I can mention it. So Ruben Ng, who is in Singapore now, but trained under Becca Levy at Yale, has done studies sort of globally on ageism and showed that it went up in pandemic, which is a really, happy thought. So, so I think that's problematic. I think part of the problem there is that, I don't know about you, but when I give talks, and it doesn't matter really to what group, I'll often ask what percentage of older people live in nursing homes. And among medical students, the average answer is 70%. So if you tell them it's 0.5 to 1%, they actually look at you with disbelief. So I think all the talk about nursing homes and people dying in nursing homes has just reinforced the idea that, if old, on death's door and institutionalized, even though you can hold up Nancy Pelosi, age 80, and another 80-year-old and say, look, there is a spectrum here. You know this to be true. So a few things, but there was also just an outpouring of sympathy and good behavior. And I think if we could harness all those people, think of all the people who met their neighbors and started bringing groceries. Think of all the people, every community-based organization I know of in San Francisco was overwhelmed with volunteers to help out. And that had never happened before. Literally, they couldn't onboard enough people. Can we harness all those people to make changes in policy to pragmatics? I think that could be really huge because there is a sense. But the broken structures, it's probably the most effective form of communication involves some data with some stories, and we actually have an abundance of both. So can we start getting those messages out, writing things for the public, giving talks, getting people really thinking about this and forming the think tanks to say, how do we address this? Because what we keep seeing happens, we've been doing transitions forever, but then people, come in and they do transitions more visibly, or we've been doing delirium forever and then anesthesia discovers delirium. If this is a problem, and I'm guilty about this, I'm a much better at pointing out problems than solving complex problems, and I'll own that because it takes lots of people to do that. But I think if we had a whole big groups of us really working on this, saying now is the moment to get people excited, to get people creative. And tech, all these tech companies, they have so much money and they want to do things, but they don't have the first clue what they're doing. Usually, when we get these young Silicon Valley people that come and they'll be and I'll say, well, have you spoken to any old people? And so they think talking to me is speaking to an old people. And I'm like, right, okay, well, yes. And, maybe you could speak to someone in their 80s, not in their 50s. So yeah, I think we just need to make the most of this opportunity and tell some of the better stories too. One of the things I find really useful is when they're saying, it's 15% mortality if you're over age 80, or 20%. It kind of depends on the study. I say, so what does that mean for who didn't die? Like, oh, 85% of people, right? So constantly reframing, but also coming up with some good ideas. And there actually are many good ideas and lots of experts. We had a California State meeting last week with some of our nursing leaders, really going over the pod model. So I don't know if you guys have heard, but the greenhouse approach, which tries to make nursing homes into real living spaces. So animals, kids based in communities. The ones that have pods, whether they're tall buildings or whatever, have had much less COVID. They also pay their staff well, and so they have less staff turnover. And the staff live in safer environments. So how do we do all this? Like, people make jokes about aging and pretend not to be growing old because it's so scary, and yet by doing that, they're reinforcing the divide. So how do we get people to realize, like, really you can create a future you want to live into? And it's kind of fun, and it's an opportunity to harness tech and people in design. It's really, I think the sort of interprofessional, largely writ, not just interhealth professional opportunities here are pretty terrific. There will be the issue of funding, but there are also some big funders. There are a lot of very wealthy older people who want to create a world they can enjoy themselves. Although if they're at the very top, they'll just hire what they need into their home. But often they'll see that other people will need things too. I don't know. It's a whole conversation again.
Does anyone else have? We'll take another maybe one or two questions if anyone else has one. Yeah.
Well, I just want to say thank you for bringing racism intersecting into the conversation with ageism as well. Also, San Francisco native also. So
Yeah, I saw the hat.
very familiar with that. Very familiar with that whole parking lot situation, Mission Bay and the Parnassus one. But just knowing the facts that Black and brown populations are highly more affected by COVID. What's the call to action after that? Is it just right to our politicians to like reframe entire cities like housing and like healthcare and everything? Like what is the call to action in terms of immediately right now?
Yeah, I think it depends on sort of where your key sphere is, but if it's hard to think on such a big scale. Clearly, we can vote and make those demands and send letters, but also looking at your immediate context. What can we do for more hiring of people? We know that concordant care is better care, and concordant, like even discussing vaccines, like you discussed vaccines, and concordance leads to higher vaccine acceptance rates. Because right now the people at highest risk maybe, remain at highest risk for dying. So it has to do with recruitment. It has to do with, and at all levels, at our medical school, like who's on the faculty and what are we doing to retain people? What are we doing to recruit people? What are we doing in the medical center? What are we doing in teaching? Who's represented? Who's there? What voices are we hearing? And some of this, has been ongoing, and some of it needs a whole lot more attention. But I think if we all look at the whole big thing, we'll all be like, oh my God, like we won't do anything. But if each of us found one thing where we could make a difference, that would amplify. So pick one thing that you're excited about or that you deal with regularly and change that one little thing.
Thank you.
I just want to say thank you for, I expected more lectures like this in this school, so I appreciate it. And I've also learned a lot, and I feel like I'm one of the oldest people in the program, and I'll reframe my discussions in Botox, so thank you very much.
Yeah, no, I mean, we all do it. If we're well acculturated, we all make those jokes, and you just have to retrain yourself, and that it's kind of fun. I mean, you fail some days. I still wish I could run the way I could 10 years ago.
So, Louise, there are a couple of people saying thank you for a great presentation in the chat box, and just thank you for that. And there's also a question about your slides. Are you making your slides available, or?
Yes, your team already has them. So Ebony has them and Kathy has them. I'm not sure. Anyway, they are available somehow, somewhere.
Okay. So I'm sure
Yes, and Lisa and Louise, we will also be making the recording available.
Okay.
Look for the IOA newsletter and you'll get the link.
Okay. So again, just a lot of thanks in the chat room. Louise, I want to thank you so much for your presentation, your talk, really creating a lot of thought and discussion, as we're seeing in the conversation we've had and in the chat as well. So thank you so much, and giving us a call to action also, things that we can all do to make improvements right now without it having to be a big thing. So really appreciate that. And just on behalf of the group, we just want to say thank you and thanks for a great talk. So.
Great. Thank you. Thanks for coming and for such good questions.